So hi and welcome. My name is Melanie Escher and I'm with the Arizona Telemedicine Program and the Southwest Telehealth Resource Center. And you are joining us for our telemedicine, our CME telemedicine webinar series. So we respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region, with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So again, welcome everybody to the Southwest Telehealth Resource from the Southwest Telehealth Resource Center region, our region states, fellow HRSA grantees, and all of our other participants. So as you joined us today, we're going to go through a little housekeeping tips. Your phone or your computer mic was muted. We will be reserving time for chat at the end for some Q&A, so please use the chat function for your questions. There's also a post-webinar evaluation, and your comments are important to us and helps us bring you more educational events. So there is CME credit available for this, and it's only available during the live presentation. There is a code in the evaluation that you will be able to get. And if you did not set up your CAMS account yet, just let me know and I will send you that information. So here's a continuing medical education, the outcome objectives, accreditation statement, and the disclosure statement. Again, the code can be found in the evaluation. And if you have not set up your profile yet, please contact me. There's my email address. It's mesher@telemedicine.arizona.edu. I will put that in the chat when I'm done. Disclaimer: the opinions expressed in this presentation on the following slides are solely those of the presenter, not necessarily those of the organization sponsoring the webinar. The organization is not guaranteeing the accuracy or reliability of the information provided herein. Please check our website for upcoming webinars and events. That's www.telemedicine.arizona. And also, here's the link to the survey, but it will populate in a browser window behind your webinar slide. But I will also put that into the chat. And now to introduce our speaker today, using telehealth to treat PANDAS, Health and Behavioral Considerations, Part 2. Today we have Dr. Andrew Gardner, who is Associate Professor with the Department of Pediatrics and Psychiatry in the College of Medicine, University of Arizona, and he also is with Banner. Dr. Gardner?
Great, thank you, Melanie, appreciate it. Okay, I'm going to go ahead and share my screen and start here. All right. How does that, does that work?
Yep.
Okay, great. Okay. Well, thanks for having me. I appreciate it. I will be talking about a treatment of PANS and PANDAS, health and behavioral considerations, and then talking a little bit about the telehealth portion of this as well, since our clinic has been working with families across the nation and across the state. More recently, we closed it to just Arizona folks, but we've had to reach out quite a bit as well and to meet the need. So I'm going to try not to go over or things that Dr. Rice has already done in part 1, but I will do a little bit of that as well as it relates to what I'm going to be talking about today. As you know, our outcome objectives today are to describe how to use telehealth to better understand the biobehavioral presentations of PANS and PANDAS. Like to be able to, everybody to be able to identify some family accommodations and secondary gains within the family systems via telehealth and how you can do that. Make appropriate behavior therapy recommendations indicated by empirically supported practices as well. All right. Let's see. Okay. All right. So, gotta get out of that. Okay. All right. So, just to make sure I can go forward. Okay. Just to remind you, the diagnostic terminology that we're discussing from Dr. Rice in part 1, we're talking about CPAE, or childhood post-infectious autoimmune encephalopathy, PANDAS, the pediatric autoimmune neuropsychiatric disorders associated with group A strep, and then PANS, a pediatric autoimmune neuropsychiatric syndrome, more of a broad umbrella. So these are what we're looking for in our CPAE clinic center of excellence is an abrupt or acute onset of OCD, obsessive compulsive disorder, and or eating restrictions, ARFID, within 72 hours of infection or illness. And this is what we see. And we're also looking at comorbid symptoms of at least 2 of the 7 categories here. So it could be anxiety, particularly we see a lot of separation anxiety from parents, emotional lability or depression, sadness, lethargy, irritability, aggression, or severely oppositional behaviors. We see a lot of food refusal, but also school refusal as well. Deterioration in school performance related to attention. It's like ADHD-like behaviors that we see, but we also see, and I think Dr. Rice presented some handwriting samples that have significantly changed when for many of our children. Memory deficits and cognitive changes as well, forgetfulness, short-term memory challenges, sensory or motor abnormalities as well, oversensitivities, undersensitivities, and different things like that too. Somatic signs and symptoms, including sleep disturbances, enuresis, or urinary frequency. So these are the things that we're looking for the diagnostic criteria. There are many different variables that play into the etiology that we see. This around. Let's see. Okay, so we see, I'm sorry, I'm just trying to move my things around so I can see. Okay, so with this post-infectious autoimmune encephalopathy, we see a number of different variables related, like I said, idiopathic psychiatric illness. We see mental illness, OCD, anxiety, other things as well, neurological conditions, maybe tics or chorea, genetics that might be playing into here as well, but also what's going on in the immediate environment as well, with family stress, caregiver burden, and family accommodation. And in turn, there are child secondary gains that are occurring as well. So I'll go through these today. Okay, so the medical assessment and treatment portion of our clinic, everything is biobehavioral that we're looking at, all these different variables, and trying to figure out for these families that there's this onset of different symptoms. What is it related to? And really trying to understand it. And then the goal of the medical team that we work with is to reduce inflammation. We're trying to understand what's going on and provide a tiered treatment. So antibiotics, nonsteroidal medications, ibuprofen, naproxen, prednisone, steroids used to treat inflammation, and then finally IVIG. And so many of our patients, as Dr. Rice explained, I'm sure, go through this tiered treatment from the medical side or biological side. As you can see here, we have a number of different collaborators, immunology, psychology and behavior analysis, developmental behavioral pediatrics, sleep, child and adolescent psychiatry, GI. We also have a basic lab and basic science lab as well, and nursing. So it's interesting that it's a 2017 article, a Tiedemann article, where they talk about psychiatric and behavioral interventions for PANS and PANDAS. They state that while underlying infectious and inflammatory processes in PANS and PANDAS patients are treated, psychiatric and behavioral symptoms need simultaneous treatment to decrease suffering and improve adherence to therapeutic intervention. This is pretty broad, and it's interesting. When we started as part of the CPAE team in behavior analysis psychology, entering and looking at the behavioral pieces to this, and environmental, the parenting, all of those variables, we were thinking, wow, there's no specific recommendations exactly for just PANS and PANDAS. Everybody should go this route, like CBT therapy or whatever it may be. So we really tried to look into, okay, how can we assess well for what's going on, and then also how can we really move into reducing the challenging behavior, improving appropriate behavior, and adherence to what's going to work. And we really leading families into empirically supported behavioral interventions, as well as parent management training and support. So in conjunction, so as a team, this is what's really great about I enjoy about our clinic is, we'll round robin the families. So we will all see them separately. And then we get back together at 10 a.m. and we discuss for half an hour what's going on, what's behavioral in nature, what's biological in nature, what's medical, what's genetic, what could be going on with everybody. And so then we discuss treatment options and move forward with the family. So we have similar but different, the goals and how to help our families. So well, there's many rural families and families that can't get to Arizona. We used to do a lot more telehealth, and then we restricted it more to Arizona. So we still do some telehealth, but it is across our state. There are a lot of different ways to reach our families through telehealth. But these are some variables, thinking about access to telehealth services. Do rural families have a location they go to, so for telehealth services at a specific site, with equipment provided? Is it a pediatric practice, outpatient clinic, school districts, and classrooms? So as we know on some of our border town clinics as well, that might be an option for rural families to go to a specific clinic site. Nowadays, there are a lot of folks that do have equipment in the home as well, but it is important to always think about, do they have a desktop? Do they have a monitor? Do they have a laptop? Is it through an iPad? Is it their phone? The quality and bandwidth of their internet access. Do they have a decent camera that's going to work? Headset, can they have hands free if they're going to actually be working with their child or wrangling them to be able to be part of the telehealth visit? Internet access, of course, and then the software too. Do they have the software to be able to connect in that way? So these are all things, thinking about how can we provide and what is the access to telehealth services for each family that we might serve, and looking at these things. We were looking at the research on, how much can you provide, because our families are very, very complex at times. And some of the challenging behavior that we do see, everything from self-injury to aggression and disruptive behavior, property destruction, those kind of things too. What can we do, or what's been done? And so we're looking at some different research areas, and we found some where discussed play-based language interventions that have been done via telehealth, skill acquisition, telehealth ABA principles for basically teaching formats for children with autism and challenging behavior as well, and then teaching and coaching parents in homes and schools. And this is a growing body of literature as well, being able to assess and understand challenging behavior, exactly some of those behaviors that we were discussing through a functional analysis or functional behavioral assessment. And then implementation of behavioral interventions as well, such as functional communication training and parent management, things like that too. So there is a precedent for providing these types of services via telehealth. And so we are able to provide some assessment. We do screenings with the CY box for OCD. We have done in the past the full assessment in that way, but we have most recently been providing these follow-up sessions for our families and with the behavioral interventions and parent management training. And we've had quite a bit of success with the number of families. So that's been helpful. Things to consider, we know with telehealth services, the poor video or sound quality, sometimes we do have blurred screens or the sound isn't working or whatever it may be. So sometimes we're picking up a phone, right? And it's like, okay, can we just call? Is that going to, for this session or whatever it has to be? Technical difficulties are often hard to fix, especially if parents aren't very savvy with things too, or we aren't as therapists too. It's can be really tough. Equipment capabilities, are we able to use the camera as we need to see the child or not? Comfort of the families using technology in general. Most people are pretty good at FaceTime and things like that too nowadays too. So it's pretty can be pretty smooth for many families. Our coaching skills of our therapists. Can you provide therapy and in psychology, ABA, a therapist counseling, have you done it via telehealth? It's a different skill set sometimes to be able to provide those services that way through that medium. Administration issues, thinking about policies and permissions, HIPAA compliance, et cetera, that we need to think about for telehealth as well. So, one of the things that we do use as well is we use the TAR-FARS, a treatment acceptability rating form revised. I really like this tool. It's something that we've been using for a very long time. And this is a set of 29 families that we were able to receive feedback basically on treatment acceptability of our behavioral treatments, which include a number of different things. And I'll show you kind of our framework and model of what we work from. But asking the families, right? How acceptable do you find the treatment to be regarding your concerns about your child? How likely is this treatment to make permanent improvements? How costly will it be? Can you carry this out? Is it time consuming? Are you confident it'll be effective? So asking families and how they feel about these things. So we have been collecting more data on those in these areas about treatment acceptability because it's important to be able to understand those things for moving forward and then quality services. So it's interesting when a lot of our families come in and they're having all of these different changes, acute onset of OCD or ARFID, and then you got all this slew of other behaviors that are going on. Is it biological? Is it behavioral? What's going on? The question we get all the time is, can my child control their own behavior? The other question is, when can I start parenting again? Those are two huge questions that we get all the time from many families because things are just in disarray and it can be very difficult. So, thinking about on the behavioral end and the assessment portion, we really are looking at a baseline assessment. Like, what did the child look like, prior to the infection or the date of onset of these neuropsychiatric challenges? So one, we look at the structural piece of the family system, right? So one is their daily routine, things predictable, rules, requirements. What do their parenting and structure look like before that, right? And that's interesting to know because did they change anything as well? So, and then the functional piece as well. What are consequences for appropriate and inappropriate behavior? What do you have in place? Do kids do chores? Do they not? And so really looking at, was there challenging behavior before this as well, or not, right? And was it related to something else? And so we try to gather as much information from parents, from teachers, other healthcare providers. We provide families with data sheets. I'll show you some of those things as well. Permanent product, such as handwriting samples and things that we try to get as well. Many families provide us with videos of okay, this is what the tics look like, or this is OCD. And now, the family's living in one room of the house and the child's taken over the rest of the house. So these kinds of things where, what information can we gather to look at these basic variables first? So next, we really started looking into the area of family accommodation and secondary gains. And so thinking about this, family accommodation, the definitions, we're thinking about family involvement in routines that exacerbate and maintain either serious problem behavior, anxiety, OCD, etc. So the changes in behavior can be related to biology alone, but research indicates that sometimes as children persist in challenging behavior, parental behavior also changes, especially when a child is ill and parents are burdened over time. So as the challenging behavior is occurring, a lot of families will accommodate to it. So we have families who come in and are doing the compulsive behaviors with the child. It's like, oh, you wash your hands. Okay, I'll wash my hands too. These kinds of things, like for OCD. or they're actually exacerbating things by accommodating, but they don't realize it. So there's a systemic cycle that we see with the family accommodation, and the parent might see up in the right-hand corner, you can see child anxiety and distress. It is very hard for us as parents, of course, to see our child or our children in distress, because we want to do something and fix it, right? We want to change it so they're not in distress any longer. But at times, parents are tired. There's caregiver burden. It's like, oh, this is a lot, and I don't understand what's going on, and it's really difficult. So I have low parental tolerance for what's going on. So I start accommodating, right? So a family might start accommodating. It's like, okay, fine, you can have your iPad all day, and that's fine. I know you're ill. There's something wrong. So you can stay on the iPad. That's okay. So there's a short-term reduction in distress from the child, maybe. And then you have this continued dependence on parents for regulation, and you have this kind of maintenance of symptoms that occurs. So some of examples of family accommodation, and then secondary gains. Think about what's the child getting out of this that are secondary gains to the accommodation, and how these are related. Parents may provide repeated assurance. So we do have kids who ask the same questions over and over and over, and the parents are like, oh my gosh, I can't take it anymore. They just keep asking, about this, and it's really tough. So we do see that. Parents may allow the child to sleep in the parent's bed. Well, you're sick, you're having trouble sleeping, come sleep with me. And that becomes a habit or a pattern as well. And again, we're not blaming parents, and it's very inadvertent, and parents don't realize that this happens a lot of times. So we do make families aware of a family accommodation, and we're very straightforward with that. So it's like, wow, dude, how much are you accommodating to that? And it's been really difficult, so I could see why you would. So it's not, it's not a blame thing at all. It's just like, where are we at right now? Facilitating general avoidance and avoidance of social and school engagement. So kids stay home from school. Do a lot of times due to anxiety, they provide items to mitigate anxiety, doing things which fall under the child's responsibility. So yeah, okay, so your sister could take over your chores for the next month, preparing special meals because we want to feed our children, but they're not eating, so all of these things that can occur. There is a negative impact of a family accommodation. So it does promote avoidance of things. It reduces self-regulation. It reduces insight for the child and thinking about getting better. And then it does reduce motivation for treatment as well. So this whole area of family accommodation and secondary gains has been interesting to look at through our clinic. And so how do they impact families? The more you accommodate, and what we know is the more you accommodate, things don't get better. So the other area that we merged with the family accommodation is the 30 years of research on challenging behavior in general. So, for example, in the applied behavior analysis field, there are some really great studies. This one has 981 functional analysis studies have been published since 1961, and Gracie, Beavers, and crew here, they summarized a lot of these and looked at specifics with these functional analyses. And what they found was they were able to distinguish 4 different functions or reasons why things were happening. And they fell into 4 major categories. And so you see here that there are 4 major categories. One is for escape from tasks. One is for gaining access to attention. One is gaining access to tangible items and preferred activities. And then there's an automatic function as well, and reason why challenging behavior might occur. And so I'll talk about that in just a second too. So one of the ways that we start explaining to families why challenging behavior might occur is through, I really like, these kind of models and things too. And so we break it down into 2 different branches of variables. And so it's like challenging behavior could occur to gain for a gain function, right? So to gain access to something. One is gain access to parent attention. One of the questions we always ask is like, how does your child do when you're on the phone? And I go, oh my gosh. So it's always an indicator. It's like, oh, there's some attention seeking stuff going on. Well, they're constantly, interrupting everything I do and I say, or they're punching their sister and then I have to stop them and they fight, I'm like, okay. So challenging behavior could occur to gain access to attention, gain access to preferred activities, toys, food, any tangible item or preferred activity, gain access to stimulation of some sort as well. And this is what we see with the automatic function, where there's an input and it's like stereotypy and those kind of things too, repetitive movements that the body reinforces and something feels good about it and it's okay. The second branch we talk about is challenging behavior can occur for an escape function or to escape things that might be unpleasant or aversive, whether trying to escape social attention. I used to really want to be around friends, but now I'm going to engage in problem behavior to socially distance myself. And so we do see that. Very common is to escape non-preferred activities, tasks, and demands. So now I'm going to engage in problem behavior to try to escape, get out of the classroom, get out of chores, whatever it may be. I don't want to shower any longer, those kind of things. And then to escape stimulation as well. So there is that piece where there's also challenging behavior to escape something internal. I'll show you a big area thinking about OCD or tics. This becomes an interesting loop. It's a negative reinforcement loop that for the stimulation, which is escaping the anxiety by engaging in the compulsive behavior. Okay, so this is how we often present this to families and to other therapists and people who train with us too, and looking for these types of functions or reasons why challenging behavior occurs. So these are just some ways that parents with children who are ill often let their parenting contingencies relax and do accommodate. So for the escape function, you do see they no longer require the child to complete tasks or demands. The attention function, separation anxiety, they're very demanding of the attention of the parent. They provide more attention to a child than usual due to that illness. My child's sick, I'm going to pay attention to them. You have to go to appointments with them. They're home from school. So we do have a lot more going on or providing attention. And then the tangible function is refusal to transition off items, accepting no. They stop tolerating or accepting no, and they won't tolerate it. So having a child having free and unlimited access to the preferred items, a tablet, video games, television, whatever it may be, and then you ask them to get off and come to the table. Well, I don't want to eat. Okay, well, and then you might have a big tantrum. And things as well. So these are different functions and how accommodation fits within this framework as well. We've developed a tool called a FOBMed. We fashioned it after the MCHAT actually, and this is what we use in our clinics. We're going to be publishing on this in hopefully next month. We're submitting the manuscript, but this really looks at each of those functions, and it's a semi-structured interview. And the first part, the questions are really directed at attention-seeking behavior. Like I said, does your child have difficulty when you pay attention to something or someone else? Make a phone call, so you see these, if it's a yes, and then, okay, good. Well, then what happens after the challenging behavior? What do? Do you tell them to stop? So you're looking at the consequences as well as the structural pieces too, and kind of those triggers that we're looking for. We have an intensity or severity rating on there, as well as a frequency, how often it occurs. So if you do this multiple times, you can see changes over time in either function, changes in function, severity, or frequency, and that can help us. Is our treatment working as well? So, right, it can help us in that way. The second area you see is the tangible items and preferred activities. And then the third area is escaping from demands and things that I don't want to do. And then that fourth area is really looking at those automatic things that when kids do things alone, they're in their room and they're engaging in the OCD behavior, stereotypy, they might be self-injurious, hair pulling, whatever it may be. If they're doing it completely alone, devoid of social contingencies, then is it something that the body is providing reinforcement? It feels good to engage in that behavior. And so that's what we would call more of that automatic reinforcement or sensory input reinforcement. So, okay, we also have developed a teen version of this. So we sometimes will separate the parents and a teen who might come in and do the FOBMED teen with the teen and then compare. And we have had families who it's like, oh yeah, I pay lots of attention to my child, and the teen will say, oh, yeah, I haven't seen it for 2 months because he's on business. I'm like, oh, okay. So it's really interesting what we see in the information that we get, but it can help us understand what the child or teen really wants as well, which is important too. Do they need more attention from parents? Are they seeking that out through inappropriate methods, or whatever it may be, right? So, okay. All right, so I want to talk a little bit about some of the treatment recommendations based on behavior and function that we often provide. In this way, I kind of mentioned this too. We have the negative reinforcement paradigm that we talk about with OCD. For example, the intrusive thoughts that cause anxiety, right? So, oh, germs, my family's contaminated, and these intrusive thoughts, and my anxiety is going through the roof. Now I engage in the compulsive behavior. So I'm going to hand wash, and it releases some of that anxiety just for a moment, right? And so then I'm like, oh, okay. And then step back, and then here comes the intrusive thoughts again, right? And so germs, contamination, and it goes back up, and I engage in the compulsive behavior, hand washing, and it decreases just for a little bit. So this is the negative reinforcement loop that we see at times with true OCD. And we do see kids who have this OCD fatigue. They are tired. These thoughts are coming back, and even though you're caught in this loop, and it's tough. Tics, very similar. You have this urge to engage in a tic, and working with that. Can we tolerate the urge there present, but not engage in the tic, those kind of things as well. And it kind of leads into the therapies as well. Stereotypy is automatic reinforcement, is repetitive movements that seem to have no function, but maintained by something in the body. It feels okay. And then thinking about, I know sometimes the families come in and it's like, oh no, they're obsessed with their tablet. And it's like, well, is that just a hyperford activity? And they're just looking for more positive reinforcement from it, and it's just enjoyable, right? Or is it OCD? And I think that's kind of hard. The other thing is we do see kids with autism in our clinic as well, and PANS or PANDAS, and it's hard to tease those things apart. Is it OCD? Is it stereotypy? Is it hyperford? Is it being rigid as the symptomatology of autism? So these are hard things to tease apart at times. And so, yeah, it can be challenging. So it's nice to have different eyes on the behaviors and different ways of looking at these behaviors. All right. So we really try to individualize treatment, providing the family support and therapy. We talk about minimizing family accommodation to the OCD and other behaviors, in turn decreasing the secondary gains, which can be really hard as well. The dynamic changes in parenting structure and styles with fluctuation in symptoms. What we do see, if it's PANS or PANDAS, as children are exposed to maybe, symptoms have gone away for a little bit, and if they're exposed to infection, maybe at school, you see some of the behaviors come back. And this is what we'll talk about, flares or flare-ups. And, this absence of infection, are they back to normal? But what do the families do during these acute phases or these flares? So one thing is, do they keep their parenting the same? Are they accommodating more? And families will realize like, oh, yes, I have been accommodating a lot. And so we, help them. It's like, how can we, get out of that pattern and disrupt it to move forward? And so in one of the, of course, like the biological pieces with the behavioral pieces, this is definitely the partnership and collaboration is huge in that way as well. Okay, so for example, one of the things that we do, or here's just some examples of things that we do for attention maintained behavior, right? So on the FODMAD, we see, oh yeah, there's a lot of attention seeking stuff here, and actually, here's some things that we can try from the research. So these are basic behavioral principles, and we're tailoring them to the child and the family, and they're function based, again, related to the function of attention, right? So we want to promote functional communication or functional communication training, for example. Get the child to request to hang out more. So don't be stuck at the hip, but like, you know what? And a lot of these families, it's like, I can't even go to the bathroom. I can't take a shower because these kids will not separate. So getting to start, it's like, hey, I need to sit over here for a second, but how about you ask if you want to hang out with me? And so they're like, okay, mom, can you hang out? They're like, sure. And so we want to, we really honor that request initially. And then we start having them tolerate a wait time. It's like, oh, good asking, but you got to wait for just a second. So we're just starting that to push down that road for tolerance and the separation, right? And to tolerate the anxiety that comes with it. The planned ignoring comes in place as well. And then tolerating, no, it's not right now. When caregiver attention is not available, right? Well, there's other siblings in the house and I've got to pay attention to them. I have things to do. And then planning predictable special times for high quality attention one-on-one. And so this is another thing that we often recommend, and it's on the calendar. It's like, oh, no, or throughout the day. It's like, oh, at 2:00, at 4:00, we're going to spend special time. And I have some really cool cat videos that we can, or we can play Legos together. It's going to be amazing. Can they hold out? Can we separate for that time? So these are just some examples of some of the function-based treatments that we recommend. They're tailored to each family. All right. So for mild symptoms, we often refer for cognitive behavior therapy, CBT, with exposure and response prevention focus. For moderate to severe OCD symptoms, definitely exposure and response prevention, which is the empirically supported therapy for OCD. For tics and habits, such as hair pulling, skin picking, we do some habit reversal training in our clinic for follow-ups or CBIT. But this HRT does work really well as well, and it's got a lot of evidence to support it to decrease tics. And then we have other psychiatric concerns, of course. So for RFID, we're referring to feeding therapies in clinics, and of course for psychiatry and other physicians, looking for med management as well. Neuropsychiatry, sleep, who do we need to collaborate with to help the family and really holistically look at the family and the system as well. So we might provide on our end parent management training and basic behavioral strategies linked to function and the reasons why it might be occurring. And so some of the parent management things that we work on all the time, and it's a lot of times families will come back for these follow-ups and like, okay, I tried this, it's not working. And what about, can we try something different? Sure. So let's talk about that. Are we still talking about the function? Is it the same function? Has severity gone up, down, frequency, and those kind of things? And then we might talk about, not accommodating the child's avoidance and rituals or don't participate in them. So, it's like, oh, okay. You know what, if you're going to wash your hands, that's fine, but I'm not going to do that. And, can we just allow that? And then positively reinforce desired behaviors, right? So anything, not focusing on all of the negative behaviors that are going on, but positively reinforcing desired behaviors. We use a term called the positive opposites, right? So if a child is running across the furniture, most families will say, stop, get off there, don't, but the positive opposite strategy will say, hey, show me your feet on the floor. And then we want to really praise for the desired behavior. So so that's one of the strategies that we use quite often as well. Setting clear limits, expectations, and consequences is another area for parent management training. Establishing reward systems if you need to really promote task completion and getting through demands and getting through difficult things that are hard. We have a great strategy that one of our doc students finished in looking at what we call the best choice card as well. So as we get through, we have tasks, we have choices that you can make to help you get through and problem solve your way through these things. A lot of times for our families with PANS and PANDAS, some of the kids, their communication it's not the first thing they do. They start impulsively doing other things. So can we switch to, it's like, hey, there's choice cards. They can point to it. They can hand over a card to promote better communication with the family as well. All right. So these are some of the things. We do use a lot of Alan Kasdan's work. I don't know if everybody's familiar. He's the director of the Yale Parenting Center. He's been around for years, a clinical psychologist and behavior analyst. And so there is a whole training manual. You see the yellow book on the very left, the parent management training manual. It's a manualized version of what we do. Sometimes we go through all of it. Sometimes we just choose certain specific things that are going to help that family. And sometimes the families don't need it. It just changes. And so it can be really complex. The Parenting for the Defiant Child is a really good one. We often have our families read that book as well. But these are great resources. He actually has some through Coursera, has some parenting. It's a whole little series and it's free for parents. It's parent management training stuff too. So you can kind of get he's a great speaker and easy to listen to. He has great examples and so anyhow, something that, can help families get to as well. So, okay. Let's see. Let's talk about a little 8-year-old case example, where she had an acute onset of symptoms in 2018 with a positive strep. She was engaging in a lot of different things, disruptive behavior. She was crying and complaining a lot of somatic complaints about her throat and her belly, a lot of tics and different rituals that started. And again, she didn't have any, this is a typically developing child. And then we see these within 72 hours, these changes and these behaviors. And so she became much more hyperactive. She was always moving and constantly dancing. And I have these little episodes where she just wouldn't stop. It looked like ADHD episodes, a hyperactivity piece. And then separation anxiety. She always wanted her parents next to her. She had these types of OCD type behavior, but more fears, constantly needing to talk about spiders, snakes, bugs, and that got worse with flares. And so she would ask questions constantly. And the parents were like, oh my gosh, okay. So we don't want to keep talking about this, but we have to because she keeps bugging us about it. So these were the behaviors of concern. Our medical assessment and our team started naproxen, and they diagnosed as other encephalopathy. They started the tier treatment with her, so the naproxen, to decreasing the inflammation. Our results on the behavioral side with the FOBMed, we identified that there was attention-seeking behavior and tangible functions, especially with mom. So again, the separation anxiety, she wanted attention all the time. She'd escalate to get it too. And then also she didn't want to get off her tangible items. No, I want to stay, I want what I want. And so we started into our behavioral strategies tailored to the family accommodation, attention and tangible functions, as well as the parent management training as well for follow-up. And we had really good results. And again, this is a hard piece, right? Is it related to all the biological stuff? Is it related to the behavioral stuff? Or is it a mix of things? And so I think that's, it's hard, but the family felt supported. They felt like they were going in a good direction, that their parenting was like, oh, no, we're pretty solid with our limit setting and everything too now. So we really were able to see the multifaceted pieces of our treatment, I think. So, all right. We do have a little bit of summary data. Let me make sure I have how I'm on time. We have a little bit of summary data. Let me kind of show you guys. This is our process on the behavioral side of things, record review, interview, observations, team collaboration with everybody. We discuss the case in the mornings, and then we all round robin the family and we all see them. And we use that FODMED tool on our end to determine the hypothesis or a function of behavior, and then provide parents and caregivers with empirically supported practices and resources as well. And treatment linked to function, either parent management training, exposure and response prevention, ACT, habit reversal training, CBIT, whatever is the empirically supported piece there. And then we're also looking at treatment acceptability. So using the TAR-FAR measures to be able to see, it's like, are our behavioral treatments acceptable to these families? So one of the things we like to use, and so when parents will collect data for us, we like to use these scatter plots. And so this is for one of our older guys. He was a teen, but you can see no behavior, mild behavior, moderate, and severe. And this dad was very invested in, he's like, okay, I can take these data. And so this is a lot, you can see from 745 to 220, he said, this is when a lot of the challenging behavior occurs. And then you can see some of it was very severe, hitting, pushing, grabbing, kicking, property destruction. On that first week, like you see February 1st through the 5th, a lot of severe behavior. And then it does get better. And you can see down here where he put, on the different dates, what was going on. And so, for example, he started naproxen on the 6th, which is kind of interesting, right? So that correlates with, okay, things started getting a little bit better. That's still a big one on the 9th though, right? So you can see how he was angry that his electronics had been taken away for a while. He stole the keys to my car, got his electronics, and so et cetera. So you can see this is really a helpful tool to gather information on what might be occurring. You can see more here where, he listed it out beautifully, right? So if we had all these data all the time for help our patients, it'd be amazing. So we also see, we also try to do some timelines with certain families. This is a family that we saw over years for sure, where there was a lot of biological interventions. And then we also started the behavioral interventions and working with the family in the home, actually. So you can see, sometimes we bring them into our clinic in person, or you can do this via telehealth, where you're actually setting, hey, show me when you do, for example, take away the tangible item. What happens can we observe that for a second? And then we might plot this out. So we might do that for 5 minutes and then move to something else, have the parent present their homework. It's like, okay, show us what's happening there. And so can we see that? And so, yep, let me present the homework. And then he's doing it to escape. And it's like, oh, okay, so that's helpful. So that gives us more confidence in our assessment of function and then moving into treatment. And then you can see we do also some treatment graphs and seeing how things are going. So requesting, using words more versus disruptive behavior, kind of looking at those things. And then at what point, like, for example, a biological thing, or a biological treatment was introduced, IVIG, for example, in sessions 9 and 10, and you can see different things there. So, all right. So here's just a brief summary of 40 cases that we had. We have, you can see the challenging behavior, kids that were diagnosed with PANS and PANDAS versus no PANS or PANDAS. You see disruptive behavior is a really popular one, non-compliance as well, some aggression, and then self-injury's behavior was seen mainly with our PANS and PANDAS kids. The functions you can see as well, what we were identifying as attention seeking, tangible seeking, or escape, or automatic. For all kids, there's a lot of escape stuff. So trying to get away from things that were unpleasant or aversive in nature was pretty prominent there. And then with tangibles next, and then attention. So some of the automatic stuff for more of the PANS and PANDAS kids, which is kind of interesting. Again, treatment acceptability rating form, getting more information. Are we going in the right direction for these families? And since the article states some really broad things, where you're like, well, does parent management training, behavioral strategies, and therapy, and of course the empirically supported pieces for OCD, for tics, and motor tics and vocal tics, are these acceptable to families? Okay. There's so many research questions still we need to look at, right? So biobehavioral interventions, thinking about behavioral treatments and therapy, what are the combinations, that we've been doing, or what's best or most effective, dosage, timing of both, right? So we might have the medical piece, but we don't know how much of the behavioral piece, is more effective. The timing of it, does it matter during a flare, during just post-infection, is that going to be helpful or not? Or is it moving upstream? It's really, really hard. Control monitor behavioral therapies along with biological interventions. Can we measure them better and keep control? Randomized controlled trials. Neuroimaging is another area. Could we use training protocols for our CPAE kids? And then long-term treatment variables as well. How do behavioral treatments and parent management training hold up against flares, exposure to subsequent infections that the kids might have, and challenges to structure and consistency in the home and parenting practices? Do we see regression, resurgence, challenge of behavior or not? So these are some things, that we still don't know. I think there's a lot of room for research and areas where, working, with other providers that are working with kids with PANS and PANDAS and other CPAE challenges can be really helpful. All right. Well, that is my my content. I think we're at a good point. Melanie, I'm going to stop sharing here.
Great. Thank you, Dr. Gardner. Looks like we've got one question over in the chat. And the question is from Dr. Rice: is working with this population different than working with non-PANDAS clients or patients?
That's a great question. We get the label of being diagnostic agnostics sometimes because we do our assessments and we treat the behaviors, right? And so we really are focused on the observable that we can see, and of course, the underlying pieces as well. But we are trying to assess for all behaviors that are challenging, right? And so, and the severity, right? And so we try to figure that out as well. So, stereotypy, like repetitive movements can occur, but once it maybe, something, one guy who always hits his thumb, right? But once it's causing tissue damage, it becomes self-injury, and then, okay, we need to see what's going on a little bit more and dive into that. But whatever the behavior may be, we will really try to tackle it. We're going to try to assess why it's occurring. So we do use the FOBMed tool for many different behaviors and diagnoses. And so we're able to do that. And then we tailor our treatments to the function. And that's where that function-based link can be really powerful. It's wonderful to be a part of a team where we can all talk and discuss what's going on, because these are some complex cases. And sometimes I feel like, wow, this is great. We figured it out. And then sometimes I'm like, I don't know really what's going on, but here's what we can offer. And it's tough, but it can be, these families often come back for follow-up. And it's wonderful to see the progress, but how can we also be there and continually individualize our treatments to our families, because they're all unique and different for sure. Similar symptoms for sure. So yeah.
Thank you. So again, if there's any other questions, please go ahead and use the chat feature and put that in there. I'm going to go ahead and put in the evaluation link again so that you can go in and request your CME credits. There is a code within the evaluation that you just text to once you get your CAMS account set up. And if you haven't gotten that set up, I can get that information to you. Got just a couple more minutes here. I don't see any more questions. Any other final thoughts about the process? And I greatly appreciate both you and Dr. Rice giving these, being part of our webinar series. Dr. Rice was last month, and these are being recorded, so you will be able to check these out on our website after the fact. And if you wouldn't mind just sending me your slides, then we'll create those as a handout then too when we're done, Dr. Gardner.
Sure thing.
So any other thoughts? Putting you on the spot.
I know. I think that, really leading families to the empirically supported practices is huge. Families don't know where to go. even just for OCD, right? Or for tics, it's just, it's like, where do we go for challenging behavior? Who do you go to? And so I think, empowering parents with being good consumers of science can be great too. It's tough, yeah, for sure. But I think that's key as well. Families try all sorts of things and they read all sorts of things, and we get a lot of interesting reports back of things people tried or don't understand, or how do they get to our clinic. It's always interesting too. So, but
you
yeah.
guys have a great service. There's a lot of families that could use that help and use that support. That's definitely for sure. I learned a lot listening to both you and Dr. Sidney, Dr. Rice, talking about PANS and PANDAS. So if I don't see any more questions coming in. So please, by all means, check our website for upcoming webinars. We do try and do one every month. And Dr. Gardner, it was great having you with us today, and look forward to hopefully working with you guys again with more updates.
Thanks for having me.
Great. Thanks, everybody.
Thank you.
All right. Bye-bye.
Bye.